Thank you very much, Tom, for that wonderful summary of surgical augmentation of the sphincter. Now it's my privilege to introduce Stuart Spechler, who will tell you why you were wrong about those statements. Stuart is Chief of GI at Baylor Medical Center in Dallas. Stu?
Thank you, Kid. Okay. Thank you. Before I start my talk, I do want to take this opportunity to just clear up a little misconception from yesterday when Steve DeMeester had me stand up next to Felice. Felice as the example of the young, progressive, young, progressive, and good, and me as the example of everything old, obstructionist, and evil. Okay, well, we're going to see here. I'll accept the old and evil part, but not the obstructionist. But as far as Felice is concerned, I learned, and we all just learned, that she has just been promoted to a full professor of medicine, and I think she deserves applause for that. But as such, you enter the ranks of the old and stodgy. Okay. Okay, let's go on to this talk. I've been asked to talk about the AspECT trial. And AspECT absolutely was a monumental effort. It's a prospective randomized trial designed specifically to evaluate the efficacy of high-dose esomeprazole and aspirin for improving outcomes in patients with Barrett's. Patient recruitment began 14 years ago, March 2005. During a 4-year period, more than 2,500 patients recruited and followed for 8.9 years. That's a big study for Barrett's esophagus. It's finally published in The Lancet 13 years after it began. And you have to ask the question, did this monumental effort accomplish what it set out to do? Before we discuss this trial in detail, let's first consider a brief history of chemoprevention in Barrett's. We've had a number of medications that have been proposed. They're all on this list. Today, I'm just going to focus on the acid-suppressing medications and aspirin because that's what AspECT focused on. Now, why might acid suppression with PPIs prevent cancer in Barrett's? We know that acid causes reflux esophagitis. That's a form of chronic inflammation. And in many organs, chronic inflammation predisposes to cancer. Think of pancreatic cancer, H. pylori gastritis, and gastric cancer. We know that PPIs heal reflux, and healing with chronic inflammation might be expected to prevent cancer. Next, acid's been shown to cause DNA double-strand breaks. That's a severe form of DNA damage, and agents that cause DNA double-strand breaks are considered carcinogens. And of course, if you get rid of that with PPIs, you prevent exposure to this potential carcinogen. There are studies to show that acid might promote proliferation in Barrett's. Again, that might predispose to cancer, and we might prevent that with PPIs. And acid stimulates esophageal secretion of pro-inflammatory and pro-proliferative cytokines. If you knock out the acid, then you prevent that. All of this suggests that PPIs might be potentially cancer protective. And let's just very briefly review some of the original data on this issue. Phospho-H2AX is a marker of DNA damage. DAPI is just a nuclear stain for DNA. If you treat these cells in culture with hydrogen peroxide, which is very well known to cause oxidative DNA damage, you get double-strand DNA breaks that you can see with these green foci. If you treat those same cells with acid, you get DNA double-strand breaks. So acid is a potential carcinogen in this condition. Now, in this study, we took Barrett's biopsies during endoscopy before and after we perfused the esophagus of Barrett's patients for 5 minutes with acid. And here are the results of Western blots on the biopsies from those 6 patients. In all 6, brief acid perfusion caused a substantial increase in DNA damage, showing that acid causes DNA damage not just in cells in a dish, but in patients in vivo. If you take biopsy specimens of Barrett's, put them in organ culture, and expose them to acid, 12 and 24 hours later, they show evidence of proliferation. Let me skip through a couple of these. This is a slide that just shows that if you normalize acid reflux, you prevent proliferation. So all of this suggests that PPIs might be protective of cancer. But there are also reasons to suspect that PPIs could promote cancer development in Barrett's. You remember that gastric acid secretion is stimulated by that hormone gastrin in the antrum, and in a classic feedback loop arrangement, that gastrin stimulates acid production in the fundus, that fundic acid turns off gastrin in the antrum. If you take PPIs and turn off acid, there's nothing to stop gastrin from going up, and it does, and gastric is known to increase proliferation in Barrett's metaplasia. Also, by putting patients on PPIs, you can promote bacterial colonization in the stomach. These bacteria can deconjugate bile acids and convert dietary nitrates into potentially carcinogenic and nitroso compounds. And pancreatic enzymes that ordinarily would be denatured by acid in the stomach now have the opportunity to reflux back into the esophagus and do damage. So these are all reasons why PPIs might be cancer-promoting in Barrett's esophagus. So there's plausible mechanisms for both sides of this argument about PPIs. They have some effects that might promote cancer. They have some effects that might prevent cancer. Do we have data to suggest that the rising incidence of cancer in this country in the esophagus might be due to the use of these PPIs? Well, this slide shows the rising incidence of esophageal adenocarcinoma since 1975, and PPIs were introduced late in 1989. Clearly, the rising incidence predated the introduction of PPIs. PPIs can't be the sole cause of this increase. Now, consider this meta-analysis that was published in 2014. This is an analysis of how PPIs might influence the risk of developing high-grade dysplasia in Barrett's. It's a forest plot. Okay, odds ratios less than 1 favor PPIs, greater than 1 favors no PPI. And the meta-analysis shows that the overall adjusted odds ratio here is 0.29, meaning that the use of PPIs was associated with an impressive 71% reduction in the risk of cancer. That seems straightforward, but just after this meta-analysis gets published, we see 2 large case control studies on the same issue that came to the opposite conclusion. This study of all patients in Denmark diagnosed with Barrett's, the relative risk of developing high-grade dysplasia or cancer in long-term PPI users was 2.2 if you were low adherence, and 3.4 if you were high adherence. So this suggests that PPIs actually might increase the risk of developing cancer in Barrett's esophagus. And if you add the results of this study, as well as another one that we'll discuss in a moment, to the earlier meta-analysis that I just showed you, now the confidence interval crosses 1, meaning that the decrease in the incidence of esophageal cancer with PPIs is not statistically significant. But all of these observational studies suffer from severe biases, especially this one. Some observational studies have found a significant association between PPIs and cancer, so should you conclude that PPIs are a risk factor for cancer? Well, remember, GERD is a risk factor for cancer, and we use PPIs to treat GERD. So it seems far more likely that the indication for the PPI prescription, namely GERD, is the risk factor for cancer, not the PPIs. And this is an example of confounding by indication. That's a bias that is very difficult to eliminate from any observational study on PPI side effects. Now, here's a study that attempted to minimize this problem. This is a population-based cohort study of all adults in Sweden who got treated with maintenance PPIs. It included almost 800,000 patients, more than 3 million years of follow-up. The overall standardized incidence ratio for developing cancer in patients on maintenance PPIs, 3.93. If you limit it to patients taking PPIs for GERD, much higher SIR. And that's what you would expect with confounding by indication, but they found that the SIR for esophageal cancer in adults taking PPIs for NSAID use was still increased. And based on that and other data, they concluded that long-term use of PPIs is associated with increased risk of esophageal adenocarcinoma, even in the absence of other risk factors. However, this study only decreases the problem of confounding by indication. By no means does it eliminate the problem. And shortly after that, we saw this report, nested case control study, male veterans with Barrett's. From this cohort of almost 30,000 Barrett's patients, the investigators identified 300 who developed cancer after they're diagnosed with Barrett's. Those are the cases. 798 patients without cancer were incidence density matched as controls. And in this multivariable model, PPI use was associated with a 41% lower risk of esophageal adenocarcinoma, and high-dose PPI use was associated with an 89% lower risk, and H2 blockers, use of those was independently associated with a 30% lower risk of cancer. So, lots of contradictory data on this issue of PPIs and cancer risk. What about NSAIDs? Why should taking NSAIDs prevent cancer? Aspirin and other NSAIDs inhibit cyclooxygenase. Those are the enzymes that mediate the production of prostanoids from arachidonic acid. COX-2 expression causes increased proliferation and decreased apoptosis in Barrett cells. Cellular levels of COX-2 have been shown to increase as Barrett's progresses. And COX-2 inhibition with NSAIDs has been shown to decrease the growth of Barrett's in cancer cells, to decrease the development of tumors in rodent models, and to protect against cancer development in a number of epidemiologic studies. In addition, aspirin also inhibits the NF-kappa B pathway. That's a pathway that's both pro-inflammatory and pro-proliferative. So let's just look briefly at some of these data. This study shows that COX-2 levels in esophageal biopsy specimens increase as Barrett's progresses from metaplasia to dysplasia and cancer. Skip that one for now in the interest of time. In this, this is a rat model. I think this is from your group, Ken, and also shows that it's protective. This is a meta-analysis of epidemiologic studies on NSAID use, and it suggests that the use of aspirin or other NSAIDs was associated with a 40% decrease in the risk of developing cancer. And here's a more recent population-based case control study of how NSAIDs and PPIs influence cancer risk in Barrett's patients. This study used 2 large population-based general practice registries, one from the UK and one from the Netherlands. Together, they had more than 15,000 Barrett's patients. For cases, they identified 45 with cancer, 12 with high-grade dysplasia, at least 1 year after initial diagnosis. The controls are Barrett's patients who didn't develop cancer. Adjusted odds ratios for the cases versus the controls for NSAIDs, for low-dose aspirin, and for PPIs, all were 0.9, 95% confidence intervals, all crossing 1, meaning no statistical difference. So this study concludes that the use of NSAIDs, PPIs, and low-dose aspirin were not associated with significant reduction in the risk of cancer and high-grade dysplasia in Barrett's. Well, are you tired of hearing about all this contradictory data? Well, I love that dog. I know I'm very tired of hearing about it. Some studies say that PPIs protect from cancer, others say they cause cancer, others say they do nothing. All of these reports conclude with a statement that we need better studies to validate the conclusions. And of course, a randomized trial would be ideal. Well, enter the AspECT trial from the UK. Let's see if this prospective randomized trial resolved the controversies we just discussed. Okay, the aim of this trial was to evaluate the safety and efficacy of aspirin and esomeprazole for Barrett's patients, and specifically, they evaluated the ability of these agents to reduce a composite outcome. Composite meaning it included all-cause mortality, esophageal adenocarcinoma, and high-grade dysplasia, whichever came first. This is a study conducted in 84 centers in the UK, 1 in Canada. More than 2,500 patients with Barrett's get randomized to receive high-dose PPI, that's esomeprazole 40 BID, with no aspirin, low-dose PPI, esomeprazole 20 QD and no aspirin, high-dose PPI plus 300 milligrams of aspirin, and low-dose PPI plus aspirin. And study patients had endoscopy with biopsies at years 2, 4, 6, 8, and 10, and in total, more than 20,000 patient years of follow-up, median follow-up 8.9 years. As I mentioned earlier, an impressive undertaking. Now, the primary aims of AspECT were to evaluate the efficacy of high-dose versus low-dose PPI and the efficacy of aspirin versus no aspirin on a primary composite endpoint. Again, that consisted of time to all-cause mortality, esophageal adenocarcinoma, or high-grade dysplasia, whichever came first. Now, to understand the analysis, you have to understand what they used here, which is accelerated failure time modeling. This is an alternative to the proportional hazards modeling that you're used to seeing in studies like this. The more familiar proportional hazards model assumes that the effect of a covariate, like a treatment or an exposure, is to just multiply the hazard by some constant called the hazard ratio. So, for example, studies have found that smoking increases the risk of developing squamous cell cancer more than 9-fold above that of non-smokers for a hazard ratio of 9.27. Now, in contrast, what happens with accelerated failure time modeling, this assumes the effect of a covariate is to either accelerate or decelerate a disease by some constant called the time ratio. And if your time ratio is greater than 1, it means the treatment prolongs the time to an event. This curve shows the percent of patients who developed high-grade dysplasia, cancer, or death during the 10-year study period. 13.8% of patients on low-dose PPI had that, compared to 10.8% or 10.9% in the patients in the high-dose group. That's a time ratio of 1.27. So what's that mean? If the expected time to death, or this composite, is 8 years, then high-dose PPI increases that by 27%, 1.27 times 8, 10.2 years. Supplementary data, they include a more familiar hazard model, hazard ratio for this of 0.79, meaning that over the course of the study, high-dose PPI decreased the number of events by 21%. When they looked at aspirin versus no aspirin, the time ratio was 1.24, but the 95% confidence interval crosses 1. This isn't significant. Other patients were allowed to take NSAIDs along with aspirin, other NSAIDs. And if patients using other NSAIDs with the aspirin were censored, then aspirin was significantly better than no aspirin. But look at that 95% confidence interval, just barely crosses 1. So this shows the outcome for all 4 treatment groups. When you compare high-dose PPI plus aspirin with its 9.1% rate of events, with low-dose PPI alone with its 14.2% rate of events, then the effects of PPI and aspirin appear to be additive, with a time ratio of 1.59. So it took 59% longer for these patients on high-dose PPI and aspirin to reach that endpoint. The investigators calculated the number needed to treat to prevent death, high-grade dysplasia, or cancer. It was 34 for the high-dose PPI, and for aspirin versus no aspirin, it was 43. But look at the wide range of these confidence intervals. The number needed to treat could be as high as 333 for PPIs and as high as 250 for aspirin. So wide confidence intervals. Serious adverse events. They used this scale, and only patients on the CTC-AE scale of grade 3 to 5 were considered serious. Only 28 patients, 1%, had SAEs that were related to study treatment, mostly GI bleeds. So apparently, if you take aspirin with PPIs, and all these patients were doing that, taking aspirin with PPIs, then GI bleeds are uncommon. But remember, this study was designed 15 years ago. And 15 years ago, we were not aware of all the potential PPI side effects that we are now. Things like renal insufficiency and bone fractures and cardiovascular events. And it's not clear that these investigators were looking carefully for those potential side effects. And if patients develop things like bone fractures or renal insufficiency, those events probably would not have been monitored or recorded as serious AEs attributed to the PPIs. And then with no placebo-treated group, all we know is that low-dose PPI and high-dose PPI have a similar rate of adverse events, but we really can't say that PPIs had no adverse effects. So what are the conclusions? They concluded that high-dose PPI protects against the composite of all-cause mortality, high-grade dysplasia, and cancer. Furthermore, aspirin protected against the composite of endpoint if patients taking another NSAID were censored, and the data suggests that PPI and aspirin are additive in protecting against that endpoint, and both agents were very well tolerated with few SAEs. So, is this a slam dunk for using high-dose PPIs and aspirin for chemoprevention of these patients? Well, unfortunately, I don't think so. And why not? The significant benefits of high-dose PPI and aspirin were for that composite of endpoint. It's a composite that includes all-cause mortality, esophageal adenocarcinoma, and high-grade dysplasia. But they also did secondary endpoints here. And here they looked at treatment effects on individual components of the composite. Now remember, our rationale for using these drugs for chemoprevention means specifically we use them to prevent esophageal cancer. But when you examine the effects of high-dose and low-dose PPIs on the individual components of the composite, the only significant effect was on all-cause mortality. Well, that's great, but we don't put patients on the PPIs with the rationale that we're preventing death from automobile accidents, right? We do it to prevent deaths from esophageal cancer, and the study did not find that. Now, again, there's no placebo-treated control group, so high-dose PPIs may be better than low-dose PPIs, but the study doesn't establish that any PPI is better than placebo for protecting against the composite. And for the effects of aspirin versus no aspirin, there's no significant benefit on any secondary endpoint, although high-grade dysplasia comes close. And even for the treatments that did show significant protection against the primary composite endpoint, specifically high-dose versus low-dose PPIs and aspirin versus no aspirin when you censored the patients taking PPIs, again, those confidence intervals are wide. The lower limits are so close to 1, indicating that these results are not robust. So, despite the enormous time, effort, and money that went into putting together this randomized controlled trial, I think that the benefits of aspirin and PPIs for chemoprevention in Barrett's remain unclear. So, what are the implications for our practice? Well, I think that this randomized controlled trial is strong evidence to refute the contention of observational studies that PPIs increase the risk of cancer in Barrett's esophagus. Now, granted, there was no placebo control, but the putative cancer-promoting effects of PPIs are all related to acid suppression, and there's certainly more acid suppression with high-dose PPI than with low-dose PPI, and esophageal neoplasia was not more common in those patients on high-dose PPIs. I could have to agree with what Brandt Oschlager said yesterday, that I think arguing about whether PPIs cause cancer or not in this condition is not productive anymore. I think it's a dead horse, and I don't see any reason to continue to beat that one. Now, current guidelines call for treating Barrett's patients with PPIs in the lowest dose needed to eliminate reflux symptoms and reflux esophagitis. So, should we now be recommending high-dose PPIs? Well, I don't think so. I don't feel these data are sufficiently robust to support that recommendation, especially considering that number needed to treat of 34 with a confidence interval that goes up to 333, and with all the recent concerns about PPI side effects, which I do not discount. I think those are things to be somewhat concerned about. I don't think these results support a major change in PPI management. And finally, current guidelines don't recommend aspirin for cancer prophylaxis in Barrett's patients. Should we change that and recommend aspirin? Well, the aspirin results are even less robust than the PPI data, and the number needed to treat is even higher. Now, I am reassured by the low rate of serious adverse events in patients who take aspirin with PPIs. I'm sorry they use full-dose PPIs rather than the baby aspirin that we give our patients for cardiovascular disease, because the cardiovascular benefits of low-dose PPIs are well established, and a lot of Barrett's patients are overweight and have cardiovascular disease. And it's nice to know that aspirin at least seems to be safe if you're taking a PPI. But AspECT does not establish that aspirin in baby doses is useful for cancer prophylaxis. So I think we can respect AspECT for the huge mega project that it was, but it wasn't perfect, and its implications might be incorrect. I think treating Barrett still remains a gamble, but what better place is there for a gamble than where we are right now in Las Vegas? So thank you very much for your attention.